This is about the articulated hand. And if you wanted to see the muscular attachments, in case of ulnar side, this pisiform bone and hook of hamate and the flexor retinaculum will give attachment to the hypothenar muscles. What are those? Flexor digiti minimi, abductor digiti minimi, opponens digiti minimi. So these are the muscles which are attaching to the pisiform bone, flexor retinaculum and hook of hamate. Then if you observe lateral side, this is scaphoid bone. Scaphoid bone and trapezium will give attachment to the flexor retinaculum and the thenar muscles. What are thenar muscles? Flexor pollicis brevis, abductor pollicis brevis and opponens pollicis. Then if you see the attachments of metacarpal bones, near the base at the medial aspect of the first metacarpal bone will give attachment to the first palmar intraossei. Here first palmar intraossei, where it will insert medial side of base of proximal phalanx of thumb. So from here to here, this is first palmar intraossei. Then second palmar intraossei taking origin from the medial aspect of second metacarpal bone and inserting to the medial aspect of base of proximal phalanx of index finger from here to here. So this is second palmar intraossei. If you take the third palmar intraossei, it is taking origin from the lateral aspect of fourth metacarpal bone and inserting to the lateral aspect of base of proximal phalanx of ring finger from here to here. Fourth palmar intraossei. It is taking origin from the radial aspect of fifth metacarpal bone and insertion radial aspect of or lateral aspect of base of proximal phalanx of little finger from here to here. Right? And one more important attachment here we have to remember. Ventral surface or palmar surface of third metacarpal bone giving origin to the transverse side of adductor pollicis. Bases of second and third metacarpal bones will give origin to the oblique head. Both heads will be united and inserted to the medial aspect of base of proximal phalanx of thumb. That means at this place. Base of proximal phalanx of thumb at the lateral aspect will give insertion to the abductor pollicis brevis and flexor pollicis brevis. Then opponens pollicis will be inserted on the ventral aspect of the first metacarpal bone. And if you observe here, flexor digiti minimi and abductor digiti minimi will be inserting to the medial aspect of base of proximal phalanx of little finger. But the opponens digiti minimi will be inserted here. That means ventral aspect or palmar aspect of fifth metacarpal bone. Then if you see the insertion of flexor digitorum profundus, tendons of flexor digitorum profundus, after passing in between the two slips of flexor digitorum superficialis, they will be inserting to the base of terminal phalanx. If you take the thumb, flexor pollicis longus will be inserting here, base of terminal phalanx. If you take tendons of flexor digitorum superficialis, divide into two slips and they will be inserting to the either side of the middle phalanx. It will be divided into two slips and they will be inserting to either side of the middle phalanx. These are the muscular attachments in the ventral aspect. Then if you see muscular attachments on the dorsal aspect, all dorsal intraossei are bipinnate muscles. So these muscles will be taking origin from the adjacent sides of metacarpal bones. If you take first dorsal intraossei, it is taking origin from the adjacent side of first and second. Second one is from the second and third. Third one is from the third and fourth. Fourth one is from the fourth and fifth. That means from this area. Adjacent sides means one head from here, another head from here. After taking origin from the adjacent sides of first and second metacarpal bones, first dorsal intraossei becomes tendon and it will be inserting to the radial side of base of proximal phalanx of index finger. That means from here to here. Along with that, it will be inserting to the dorsal distal expansion. And this one also like that only. Second dorsal intraossei taking origin from the adjacent sides of second and third metacarpal bones and it will be inserting to the radial side of base of proximal phalanx of middle finger. Then if you observe third dorsal intraossei, it is taking origin from the adjacent sides of third and fourth metacarpal bones. It will be inserting to the ulnar side of base of proximal phalanx of middle finger. And if you take fourth dorsal intraossei, it is taking origin from the adjacent sides of fourth and fifth metacarpal bones and it will be inserting to the ulnar side of base of proximal phalanx of ring finger. That means palmar intraossei are going away from the middle finger and dorsal intraossei are converging or coming towards the middle finger. That's what palmar intraossei are adductors. All dorsal intraossei are abductors. You can remember pad and dab. P-A-D. Pad. That means palmar intraossei. A, D, all palmar intraossei are adductors. DAB, DAB, dorsal intraossei are abductors. If you take the extensor compartment muscles, extensor pollicis brevis will be inserting to the dorsal surface of proximal phalanx of thumb, and extensor pollicis longus will be inserting to the dorsal surface of distal phalanx of thumb. Then if you take the extensor digitorum tendons, those extensor digitorum tendons will form a dorsal digital expansion. Those dorsal digital expansions will be inserting to the middle phalanx and terminal phalanx. Then dorsal surface of base of second metacarpal bone will give insertion to the extensor carpi radialis longus. Dorsal surface of base of third metacarpal bone and dorsal surface of base of second metacarpal bone will give insertion to the extensor carpi radialis brevis. So these are the few attachments. Then if you take the applied aspects, scaphoid bone is most frequently fractured bone. If there is fracture of scaphoid bone, sometimes leads to avascular necrosis, because usually two nutrient arteries will be entering into the scaphoid, medial half and lateral half having separate nutrient arteries. So medial half of the scaphoid bone supplied by one nutrient artery, and lateral half of scaphoid bone will be supplied by another nutrient artery. If there is fracture in the center, there is no avascular necrosis, because each half will have separate artery to supply. Sometimes both arteries will be entering from one side only and they will be supplying. At that time, if there is fracture, the distal part of this bone will not get blood supply, it undergoes avascular necrosis. If there is fracture here, patient will feel pain in the anatomical snuff box. This is anatomical snuff box. Here, patient will feel pain and there will be pain along the thumb also. Then another applied aspect, dislocation of lunate bone. Whenever we fall on the flexed wrist like this with elbow flexed, which leads to dislocation of lunate bone. Here flexor retinaculum is there. Here median nerve is going. Observe here. Here flexor retinaculum will be present. Median nerve is passing like this. This is the lunate bone. If lunate bone is dislocated, it comes front and it will compress the median nerve, which leads to carpal tunnel syndrome. Then another one is Bennett fracture. Bennett fracture is nothing but fracture of base of first metacarpal bone. Here at this level, if there is fracture, that fracture what we are calling Bennett fractures. The next applied aspect is fracture of fifth metacarpal bone. See here, this is fifth metacarpal bone. Fracture of fifth metacarpal bone, what we are calling boxer's fracture. Usually skilled boxers will not make fist very closely, but unskilled boxers, if they make their fist very closely and if they hit, which leads to fracture of fifth metacarpal bone, that fracture what we are calling boxer's fracture. These are the few applied aspects related to the articulated hand. I think this is sufficient. That's it for this session.